And we're very excited about this panel. I'm Judy Palfrey, and I'm a little scared to have this microphone in front of me because I'm afraid of what I'm going to say. And I've got a million stories to tell, but maybe at the end. But what I've been listening to and thinking about and reading the work of this wonderful panel is that we're going to emphasize three things: trust, hope, and expectation. These are words that we've started to hear coming through, and we're very excited to talk about what is happening in the world of self-management, what's happening when doctors step back a little bit and begin to accompany families and accompany young people, and we're going to emphasize what happens with the I can't do the math, but however many hours of the week that families and young people are not with us in our presence. So we have a star-studded panel to do this, and I'm so excited to introduce Paula Lozano, who really is leading the field of self-management, and we're going to learn a lot from her. Paula.
Thank you. So just to set the stage a little bit, self-management support, self-management is the topic of this session. And what I'm going to be talking about refers to the, self-management in children with chronic conditions. So a slightly larger group, somewhat larger group, than the children with complex health care needs. And I want to make that clear. I think that a number of the lessons that we've learned can translate to that smaller group of kids with higher health care needs. But our work that we did with the Lucille Packard Foundation was a more broader population. And there are lots of definitions of self-management, but I actually like Rylan Rogers the best that she presented yesterday. She said that families say, we need to live a life beyond healthcare needs. So there you go. Self-management is really what is happening with children and families outside of that healthcare setting. I'm multitasking here because I've got a laptop and this, so bear with me. We have many people to acknowledge the project we're describing today, which I'm not going to go into excruciating detail on all our methods, but we did stakeholder interviews and focus groups, and some of the stakeholders are in the room, so thanks to you for participating, and to Ed Shore, who initially approached us about doing this work, and Holly Henry and the Lucille Packard Foundation. So today we're going to talk about why we should even be talking about self-management in pediatrics as a different thing from self-management in adults, existing theories and models that we found doing a literature review, asking what are the theories, what are the models that people use to think about self-management in pediatrics per se. I will propose a model that we came up with through this work, and then share with you some of the focus group findings where we examined this shift in self-management that happens from the parents owning it, parents and caregivers owning self-management, to the children, adolescents, and young adults, and then end with some where do we go from here. So when you talk about, I know there's some adult caregiver providers in the room. When you talk about self-management, you look in the literature, there's a lot about adults. In the chronic care model, we're told where self-management sits. We're told that there's a patient and a practice team, and there's productive interactions. And there are a lot of best practices. The literature has shown us that if you want to support adults in self-management, you engage them in self-monitoring, you help them adhere to their medications and other elements of their care plan, you provide some behavior change counseling, help them with setting goals, and problem solving. But this is what we're talking about, a broad array of different conditions, and here's where the 5Ds or 9Ds or however many, the differences between children and adults are many. So when you want to support children and families in self-management, you need to say, well, monitoring, well, can he tell his parents if he feels short of breath? And how does she check her blood sugar at school? And for adherence, some children do not, so parents may want to adhere to the medication regimen, but the child may have other plans. And who is supposed to remember to pack the inhaler for a sleepover? And our meal times battles. And when you talk about goal setting, well, whose goal is it? So we see that there are these differences. And on top of all that, there is an underlying trajectory in pediatrics. Now, not all children especially children with complex healthcare needs, may have an endpoint of complete independence or complete autonomy, but there is still this movement from the child or adolescent depending fully on the parent or caregiver to help them manage their chronic condition to a situation with increasing autonomy and, in some cases, independence, where the parent or caregiver has a limited role. And this really seems to be a key characteristic that differentiates this field from adult care. So we did a literature review to look for theories, and I'm going to harken back to Chris Feutner's talk yesterday because he asked, why do we have theories? My multitasking is not going as well as I'd hoped. Okay, so but a theory, we embarked on this because we wanted to find out what frameworks are people using in the field. Once you have a theory, you know you have names for constructs, you have you can have a discussion about a model, whether you agree with it or disagree with it, and it can give you some next steps. And what we found was no single unifying theory for or model for self-management in pediatrics, but we found several themes that that came out again and again. The first is around skills and self-efficacy. So all of you who do work in adults, this should look very familiar. The skills and self-efficacy cycle that is the foundation for so much work in adult chronic illness self-management, based on the work of Bandura, not just self-efficacy theory, but self-regulation, self-determination theory, and the social cognitive theory. And so there are a number of, I should say, we looked at a couple thousand abstracts, ended up reviewing a few hundred full-text articles, and there's a good literature using this model in pediatrics. Some differences are that in pediatrics you need to consider both the child, the patient, and the parent's self-efficacy, and that there is this build up toward autonomy over time. And we thought of this as sort of the individual dimension. Another major body of literature exists around the family relationship. So I just drew a little family diagram there with maybe a grandparent, 2 parents, and 3 kids. And all of these people live in a system of interconnected and independent individuals. And family systems theory tells us that we can't understand the individual with the chronic condition and their self-management unless we really understand how they're embedded in this relationship, this web of relationships. So we did find a number of articles that really look at self-management through the family systems theory lens. We considered this to be the interpersonal dimension. And the next slide I'll show you hones in on those 2 blue arrows. So those are the parenting relationships. If that child on the lower left is the child with the chronic condition, the relationship with the parents, really, if you zoom in on that, there's a lot that's happening between the parent and the child around illness management and self-management. And a lot of this looks like regular parenting, and in this case, pertains to self-care, medication use, problem solving, planning ahead, etc. We make this arrow two-dimensional because it is a relationship, so parenting doesn't go from the parent or caregiver just to the child or adolescent, but it is a back and forth. And then the third set of literature that we found emphasized the social determinants of health and the social ecological model of Bronfenbrenner and colleagues, and more recently, Avani Modi adapted that for pediatrics. And in this model, the social determinants of health at multiple layers really play a big role. And then the final dimension is the temporal dimension. And we found one model by our colleague at University of Washington School of Nursing, Gail Kiekefer, where she really outlines as stages, as discrete stages, although it's obviously a continuum, where the child starts as completely the recipient of care and graduates through a steps of which have some sort of corporate labels with manager and supervisor, and then finally CEO of care. But I think that that's a nice metaphor. It just went blank. Did your screen go blank? I'm on slide 15. Right, but I want to go forward now. Oh, I know why. It's animated. I hate animation. I just hate it. Okay, so here we go. So we put all these four together. So we put these different dimensions together. So you've got that. There's the temporal dimension. We threw in the skills and self-efficacy cycle, where the parent is getting better at figuring things out, and the child or adolescent is learning how to do self-management. And then we put that family piece around there, and the parenting. In our model, I'll just spend a minute here orienting you to it. So now you see where all the different constructs came from, and the theories that we drew from. And at the bottom, I'll point out that the social determinants fit in there. And there's a yellow triangle and a green triangle. And what we try to convey there is that the parent, the yellow triangle, is the predominant provider of self-management in the beginning. Toward the end, their role diminishes, but we didn't cut them out completely, because we know for many, many children and youth that the parent-caregiver role will be substantial for many years to come. All right. Now I'm going to tell you a little bit about some focus group work we did. And we really, there's a lot in these focus groups, and what I'm going to emphasize today is that shift. We asked the participants in our focus group to tell us, how did that shift happen for them, or how is that shift happening from the left hand of this diagram to the right. We did these focus groups, 4 focus groups with a small number of parents of children with chronic conditions and some young adults, ages 18 to 25, with chronic conditions. Most of these individuals had a single chronic condition, so they wouldn't meet anyone's definition of complex. We had one individual who had multiple chronic conditions: hydrocephalus, seizures, Crohn's disease, and learning disabilities. But for the most part, they were single condition. And I'm not going to show you the demographics, but there was a range of socioeconomic status, educational status, severity of illness, and impact. I'm going to tell you about, I'm going to share with you some of the data we got from these focus groups around the parent attitudes of shifting this self-management responsibility, the reflections of young adults on how that happened for them, and then I'm going to describe some different parenting approaches that you could think of as sort of fitting into that big blue arrow that I showed you earlier. And I should point out, if it's not obvious from the previous slide, these are not linked parents and children. So these are parents with their own kids and young adults, not part of the same family. So when you talk about shifting from the child being from the parent being the manager to the youth being the manager of their condition, it's a given that that is going to happen for most families. For the families in our focus groups, that wasn't a question. But parents had a lot of ambivalence about it. They expressed that on the one hand, they wanted the child to develop skills and they wanted the child to be confident and unafraid, and that the normal childhood experience is not having your parent hovering around you and worrying about you. On the other hand, all of the cons were about fear. What would happen if I wasn't there or if I didn't take care of something? And the parents who voiced that opinion, for them, they talked about normal means having a normal childhood, not having to worry. He's too young to do this. So I'm going to walk you through some quotes, and here's where this double... Here we go. This mother of a 13-year-old boy with the multiple chronic conditions told us, she says, I'm more the helicopter parent, like being careful about summer camps. He went to the Crohn's camp last year. It's highly monitored by physicians and other people who are trained. I think I'm more cautious with him. I'm looking forward to college too, but oh my gosh, I might have to move to the town he's in just to be there. You know, what if he has a seizure? The mother of a 14-year-old with diabetes says, I think that's one of the hardest parts, is that you want to trust them because they're responsible. I mean, they take care of themselves usually, but it's just nerve-wracking. It's hard to give them the independence they want and still let yourself take over the care that they need. The mother of this 13-year-old girl with asthma, who had very severe asthma and poorly controlled, said she gets up in the night sometimes and I don't even know she's on the machine until I hear it. She'll be like, Mom, Mom, where she can't really get up. And I'll say, I'm right here, what's wrong, what's wrong? Other times she's like, just go away, please, I can do this. And we heard some wishful thinking too. This mother of a 14-year-old girl with type 1 diabetes talks a lot about how middle school is going to be different, and she goes, I hope it works out. So the young adults, these were 18 to 25-year-olds. Some of them were working, some of them were in college, and they had all had figured out some measure of independence. This 18-year-old woman with type 1 diabetes said, there's a lot of things about diabetes that you have to transition into when you're taking care of yourself. And it felt like for most situations, it was really kind of a forced, in-the-moment kind of thing, where it was like, I have to do this right now or else it's not going to end well for me. My parents are there, but they're like, oh, just do it yourself. Like a couple of weeks ago, I started putting my insulin pump in by myself. I was at school, at college, and my pump stopped working, and my mom is like, yeah, we can't come help you. You'll have to do it yourself. Plus you're gonna, this was in high school. Plus you're gonna be going off to college in a couple months, so you'll have to figure it out now. The 24-year-old man with ulcerative colitis says, when I was 20 and the ulcerative colitis came back, because he'd been in remission through adolescence, he says, I was kind of on my own in college and my parents were far away, so they couldn't really help me. I had to be much more on top of my situation. I had to pay attention during doctor's appointments. So college is a theme here. this 20-year-old with muscular dystrophy describes getting pneumonia, and she was going to college 5 hours away from Seattle. She said, my parents were here in Seattle, and the campus health clinic said, well, it's possibly pneumonia. Anything gets bad, you might want to go to the ER just to be sure. You never know. Your lungs aren't as strong because of the dystrophy. You want to be on top of this. I wasn't feeling so great, so I went to the ER just to check things out. I had to deal with insurance and explain my medical history and deal with it on my own. My parents called and asked, do you want us to fly out there? And I'm like, well, you can't really do anything. It's okay. It was like kind of pandemonium to transitioning to taking care of my own health. And finally, this woman with panhypopituitarism tells us that one of the interesting things that just blows my mind is when I moved from children's to adult care, they just assumed that I knew some things. When I was first diagnosed, there were certain things that I don't think anybody really told me because I was just 15. So when we looked at what was happening in these families, when we said, well, so how did this transition happen to the extent that it happened, whether it was abrupt or gradual, we kept coming back to coaching. The stories that parents told us, the stories that kids told us, that young adults, all sounded like different aspects of coaching. And I've got some examples of that here. There's a lot of things about diabetes, says this mother of a 13-year-old, whoops. Bear with me, guys. Here we go. This is the mother of the 13-year-old boy with diabetes. She says, there was one time recently when he came home and his blood sugar was a bit high, and I said, what did you have to eat? He said, well, I had an ice cream at school, but it's got the nutrition information on the package, so I know there's this amount of carbs in it, so after I had my lunch, I did it on the pump. I thought he thought I was going to be mad at him, but I said, well, that's wonderful. I'm glad that you feel like you can eat this and you're going to do the right thing for it. I think that's fantastic that you're getting more comfortable with it and taking the responsibility you need. And this other mother of a 7-year-old girl with diabetes talks about coaching as well. She said, yes, she's young, but she's capable. And I want her to saturate all the information that she's getting. So she woke up with a high blood sugar of 326 this morning. We went through the process of trying to figure it out, brainstorm what happened. So you went to bed last night, you're at 140. Why do you think you're at 326 now? I want her to think that way if I wasn't there. She's able to recount what took place to get to this. I want her to have the knowledge and skills. I don't want her to be afraid. When I see parents freaking out, I think you're basically teaching your kid to be afraid. And this mother of a boy with asthma was having a lot of struggles before and then decided to change her approach. She said, I think I let go more and let him take more control. If he said that he couldn't do something, then at that particular time, physically maybe he could, but mentally he wasn't ready. And when I started letting go and let him make decisions, it made all the difference in the world. His asthma got better, his stress got better. I have to stop pushing that button. Okay. There we go. So the young adults also perceived coaching. They told us about it in the recent past, that they had felt this, that their parents had coached them in different ways. A 20-year-old woman with debilitating migraines described staying up at night as a senior in high school and realizing that her parents couldn't stay up late, and so she says, I had to make these choices, and I wasn't going to wake up my mom and go, what should I do? I just had to be able to figure out this stuff on my own. And the woman with panhypopituitarism describes her father modeling for her how he dealt with pharmacy and insurance issues, and then handed it over to her. My dad handed that over to me, she said, so he wasn't helping me much, only a little bit. It's been difficult, but seeing what my dad has done, I have that routine. So part of coaching turns out, is allowing children to fail and adolescents to fail. And this was not something we put in that arrow. We didn't anticipate that piece of it, but we had a number of parents and young adults tell us that they had this as part of their approach to transitioning the self-management to the child. This mother of the 16-year-old boy with asthma says, I think letting them fall a bit, knowing the safe distance to let them fall, like playing basketball and not bringing your inhaler, and realizing and calling to their attention that they're in really bad shape. Or the mother of this 7-year-old girl with type 1 diabetes, she was pretty stark about it, and this was pretty recently after the girl's diagnosis. She says, if my daughter's cranky because she has to eat and she doesn't like the food that I'm giving her, I'm not letting her have any other opportunities of picking and choosing. I say, this is what you're going to eat. Then I dose her for the correct amount of insulin that she's going to eat. And she sometimes has refused to eat. And I've had to let go and say, okay, by you doing this, this is what is going to happen. If you don't eat, then you're going to get low blood sugar. And you're going to feel really crummy. And then if you fall asleep, that means I'm going to have to get the big old glucagon shot, and you'll have to go back to children's. And so that's the process. And then 15, 20 minutes later, she usually comes around, so then she eats. She needs to know, hey, I'm giving you the choice. You're not going to like it, but I've had to let go of that guilt. The alternative to what I've just been describing, the coaching and the letting them fail, is not having a plan. And not having a plan takes a lot of different forms, and some examples are here. This mother of a 7-year-old boy with sickle cell just acknowledges, she says, I don't do a good job getting him ready to take on his condition as an adult yet. She says, he's still so young. So she's just acknowledging it's not there. A lot of parents use hope terminology. I hope he can do this. It would be great if he could do this, but no action, no planning around that. And then the mother of this prayer falls into this category. The mother of this boy with multiple chronic conditions, she says it's hard to put a baby monitor on a teenager for many different reasons, and for her it was that she was always the parent who had to get up, so the baby monitor meant she got no sleep. She says, I don't have him on the monitor now. I just have to say some Hail Marys at night that everything will be okay, and that was not tongue-in-cheek. So, these focus groups have really been helping us understand what is happening as you move from left to right in this diagram, and I think they're hypothesis generating and just opening the door to start thinking about how could we ask questions of families, and how could we think about this transition in a way that prepares us to better support families as they go through this. We feel that the families in our focus groups clearly understood that there was a trajectory toward independence, but there's a great variety of ways of getting there, and letting go, this controlled trial and error, seems to be a common theme. The alternative to doing that is not planning. And the more we read these transcripts, the more we realized that this transfer of self-management tasks from parent to youth is just like parenting in every other dimension, only more so. It's the same as teaching, toilet training, homework, chores, crossing the street on your own. It falls into that same model, and it's just different content that needs to go in there. I will leave you with some thoughts that our team has been thinking about, both in terms of future research in this area and practice, developing programs, thinking about how we structure our services. And this is another question mark to go with the other question marks from this morning. What would the care of children with chronic conditions look like if we explicitly address the different dimensions of pediatric self-management? That individual dimension of thinking about how we get self-efficacy and build skills and work toward autonomy, the interpersonal part with the family systems, thinking about those social determinants, and then this temporal shift that is sort of baked into this issue. And I would say we need to think about that in terms of assessment of families, care planning, intervention development, and on and on and on. And we thought, at the conclusion of this work, that it was really fruitful to think of self-management, to frame it as a facet of parenting. And I will leave you with that.
Thank you so much. It was wonderful. Now, Amy Hotro from the Children's Hospital in Pittsburgh brings us the perspective from the rehab.
Thank you, everyone. So what I'm going to talk a little bit about is how we think about complex care and supporting self-management. And I'm going to talk about it a little bit from the rehab perspective. And what we think about when we're talking about rehab is that we want to be optimizing the health, function, and well-being of children with disabilities. And I consider children who have complex healthcare needs as a subset of children with disabilities. So functional limitations that impact their day-to-day life. That's how I'm thinking about these children. And from a model of care of pediatric rehab, which is very much based in team-based shared decision-making and shared goals and direction, is thinking about how we improve and restore function. And I think we can say that self-management or self-care is a part of the functional development that we all go through in life. And so as a pediatric rehab doctor, I think about how we improve function, not just in how someone is able to walk, how someone is able to brush their hair, how someone is able to speak or swallow, but also how people function in the very complex ways in their day-to-day life. So if you're familiar with the International Classification of Functioning, that means the relationship at the level of participation, a person in their society. We are also very much engaged in promoting development and independence. So taking a child who has had some reason that their development and independence has been challenged and working towards that level that can be expected. So a promotion, but not necessarily achieving a quote unquote typical level of development and independence. And what we do is we make adaptations for functional deficits. And that's a key point. So sometimes we won't expect our children with complex healthcare needs to be able to self-manage. So for a child, for example, who's paralyzed, they're not going to be able to self-manage their catheterization because they can't use their arms. But they may be able to direct that care very clearly and have the agency and autonomy to do so. And so while we are not setting them up to be independent with this aspect of their self-care, we're promoting a sense of agency and autonomy, which is a very natural part of development throughout childhood. We see it for the young child really trying to assert their will. And we see it in the teenager who is asserting their will by perhaps not adhering to treatment protocols. And we see it as people age into adulthood. So making adaptations, I think, is a key point of my message about self-efficacy and self-determination and self-care and self-discovery and being the owner of your health over time. The other thing that's really important from a pediatric rehab perspective is helping children engage successfully in their communities. And one thing that we, I think, got brought up here, which was really important, is that we are shifting a lens from our medical care setting into the world in which children and families live. And we need to be very cognizant that when we're talking about self-management of healthcare, that there's a whole world of management that's happening, both the child doing it on their own, self-regulating their behavior, learning when it's appropriate to do things and when it's not. And that sort of thinking, we need to be holistic and recognize the inputs from very different sectors of the world into our healthcare setting. The other thing that we try to do is mitigate the negative consequences of disease. And I think this is kind of where we get stuck in a little bit in the quagmire when there's lack of adherence to a treatment protocol, or there wasn't the follow-up that we thought that there should be. And that sometimes we have this kind of blaming mechanism about that. And as physicians, that comes from hopefully a place of good, that if we take these steps, we know things will be better. But what we need to consider is how incredibly complicated and how the realities of life fall so far outside of the realities that we see in our settings in healthcare. So one of a key component of understanding function is understanding capacity or capability and performance. How many of you have run a marathon before? Any of you? Yeah, so you didn't just get out there and run a marathon. You had to prepare for it. You ran shorter distances every day. You went on a training protocol. You were building your capability by practicing something, by performing it. How many of you have been a parent of a 3-year-old? Right, most of you. So 3-year-olds, right? Wow, they're doing so much. One of the things they're doing is learning how to get themselves dressed in the morning. And how many times were you up, going to be late to my 8 o'clock meeting, and my 11-year-old has to go to swim practice, and why is swim practice at 6:30 in the morning, and here's my 3-year-old not getting themselves dressed. And what do? You get them dressed, right? So what you're doing is doing something for them, for expediency's sake, in order to get through the day, and you're not giving them the opportunity to practice something, to build the skill and capacity for it. So for a typically developing 3-year-old, no problem. They're going to learn how to get themselves dressed. But for a child who is very medically complicated, has functional limitations, not really practicing repeatedly with consistent effort and attention to the very minutia of the steps might actually limit the child's ability to develop that skill. And if they limit the child's ability to develop that skill, we're talking about that compounding over time. So capacity is what you can do. And by doing things, what you perform, you actually build your capacity. And the example of running a marathon is a perfect one. Because at the outset, when you said, I'm going to go to run a marathon, you weren't going to cross the finish line if you just started to run. Very unlikely that you were going to be successful at that. But you ran, and you ran some more, and you ran, and you practiced, and you got better, to the point, although you were feeling like you were running up against a wall at mile 20, that you actually could perform the full 26.2 miles. So for kids with disabilities, here's a kid who is practicing in a controlled environment with someone hands-on helping her, that will allow us to get to a kid who can do this at school and participate and have independence with something. And this is an accommodation that we're making, but we're calling this success. And we have accommodated for him to be independent with this activity. He's got a backpack on. He's going to be able to take his coat off. He's going to be engaging in his day-to-day activities successfully because we went through a process of developing his capacity by repeated performance, and as he performed it more, adding more complex skills to that. So when I think about self-management, what do? We do diabetes educator comes in and talks to the patient and family, but there is not real training or real coaching for the kind of things like there is for physical therapy or occupational therapy or speech therapy. But how do we just expect people to be able to develop these skills? I think it's wrong of us just to assume that we can tell you that you have to do it, and then therefore you will be able to do it. And I also think we need to really pay attention to understanding competence. So if I talk about competence or ability to do something or manage, I'm really talking in a patient-environmental interaction standpoint. So our worlds are incredibly complicated and socially constructed, and our realities are different from where I'm sitting or standing than from you. And I told you a story about a 3-year-old and dropping your 11-year-old for swim practice because you had an 8 o'clock meeting. And I told you that story because I knew it would speak to the people who are here in this room, right? I didn't tell you the story of the mom who worked 3 to 11 and came home and there wasn't a lot of food. And she has to get up to make her 12-hour shift tomorrow, and she's on a warning from her boss that she will not have a job if she shows up late. I didn't tell you that story because that's not our realities, but that is the reality of a lot of our patients. And when we're talking about a quarter of children living in poverty, we're talking about those families being food insecure, not knowing where their rent is going to come from, not knowing if they're going to have a home next month. So these are the realities that we're talking about for a large number of our patients. And so when we put upon them our expectations and our understandings of being responsible for their health, what we're doing is something really naive, because we're not getting to where the patients and families are. And while I think all of those quotes from the focus groups are awesome, they really don't necessarily speak to the realities for a lot of families who aren't able to be activated in the same way, that don't come with the endowment of a socially constructed reality that has provided for them the habitus of social capital that they can exchange. So we have I recently took over our practice, our inpatient unit, which has 8 beds, and we had 7 kids on, and I admitted one that day. So we were all full. 3 of those children who were on inpatient rehab, meaning that they had suffered some severe illness or injury or had major surgery and had really significant functional deficits, 3 of those children had mothers in jail. 3. And 4 other of those children had child protective services involved. And the last one that I admitted that day had what appeared to be a very functional, intact family. And on my history taking, I asked what we often ask in rehab: what brings your child joy? And the mom just collapsed into tears. She hadn't had anyone pay attention to that. That's where that was coming from. But what I recognized in that moment is that this woman was on the verge of not making it. Okay, and we needed to mobilize everything that we could for her well-being, because that was going to impact her child's well-being. And so that there's so much about what we're asking people, we just need to be cognizant of what the realities are and what we are not setting them up for to give. So I want to talk about the person, so the child or the family in either case, the level of limitation that they might come to the table with. It might be limited English proficiency. It might be health literacy. There could be very low, or it could be high. It could be a lot of different factors that are endowed upon that person. Genetically, they have a low IQ. The environment, and I'm going to talk quite a bit about this, and then the activity that we expect them to do. Some activities are very straightforward, and some of them are very complicated. And it's much easier to get people to engage and feel confident in skills that are much more straightforward, especially when you understand the value of that activity. So the role that the person plays in it, I gave you the example of the child who's paralyzed, who is going to be able to learn to manage her neurogenic bladder by guiding a caregiver through a process. Well, that individual might have as much self-efficacy and autonomy as someone who's going to be able to do it for themselves. And then their competence. And then we get to this disability situation kind of all rolled up into one, how this actually plays out in society. So proficiency or competency, this is a hierarchy: novice, advanced beginner, someone who's competent, proficient, and expert. And so I feel like I probably should be an expert at navigating the healthcare system. I mean, I was a child with complex chronic health conditions. I've had them all my life. I'm a physician. I have an MPH in health policy and management. I have a PhD in medical sociology. If anyone should be an expert at navigating the healthcare system, really it should be me. I don't feel proficient or competent a lot of the time. We have a system that is set up to make it so challenging that you can't actually achieve a high status of expertise. I face, in my own health system, barriers to access to care, where I then pull out my badge, which says Vice Chair on it, to make sure that they know who they're talking to. And sometimes that works, but this is after a very long process of trying to negotiate. So we're talking about care coordination, because care coordination is really important. I tried to help for care coordination for one of my patients, one of these 8. His mother was in jail. His cousin had just tried to commit suicide. We were trying to place the child with his aunt. It was very complicated. He had multiple chronic conditions and then had a brain tumor on top of it. So needed to see ophthalmology, needed an MRI, and needed to see neurosurgery after. I'm like, our care coordinator's not here today because she's ill. I'll make some phone calls. If I could swear on the webinar right now, I would swear, because it took me 2.5 hours and 9 phone calls. Right, on the phone. Oh, that person doesn't answer the phone. They're going to call you back. Oh, well, great, because I might be in a patient's room doing something else. I'm just not readily available. I need to talk to you now. So I can't feel like an expert, even though I have all the tools that should make me an expert. So just really unfair expectations, and we need to be cognizant of what we're asking children and families to do. We also really need to be cognizant of where they are and what's important to them. And so maybe self-management right now isn't the top of the list. Maybe it's about just getting by. And I think that that's an important aspect of family-centered care. We place the family and the child at the center of what we're doing. But what we need to be really making sure that we're doing successfully is that we're navigating their needs, where they are, in the time that they need it. And so if I am asking a family that is food insecure to spend the time to start teaching their child whatever self-care skill, I have neglected to realize the realities of that patient and family's life. And I am saying, I want you to become an expert in this thing, but I haven't navigated with them the tools that they might need to do that. So a little bit from teamwork science. We do a lot of teamwork stuff in Peds Rehab, and we are very invested in a team model of transdisciplinary care. So multidisciplinary, you work in the same place, you're doing your own thing. Interdisciplinary, you're hopefully sharing some goals. Transdisciplinary, we overlap, and where we overlap, our synergistic goals improve outcomes. And so if it's me trying to help a child be independent with something, that I rely on the rest of my team to share those goals with me and to take it from their various perspectives and give to the family the opportunities to voice their concerns, create shared goals, and work towards them. It's not me handing them a goal of some sort of independence on a platter. And I, as a physician, do not have the tools in my armamentarium just to wave a magic wand and expect those things to happen. So team effort for whatever we're doing to promote independence, to promote health and wellness is really very important. And we have to be cognizant of what is reasonable to expect. And if you are setting someone up for failure, like we do every day when we ask families to coordinate their care in very challenging healthcare settings, how do you feel the strength of the value of your skills if you can never be successful at that skill? I'm sorry, we have to have care coordination, and we do it all the time because there's no way I could expect my families to get a VCUG, a CT scan, and have an appointment in our interdisciplinary clinic. They couldn't possibly arrange that because I can't possibly arrange it. And so when we talk about self-determination and efficacy, you have to have opportunities to fail, but you also have to have opportunities to succeed. And we also need to be really attentive to what those expectations are from patients and families and from our teams that we work with. So if you were in my practice in San Francisco, you might have told me that it's really very important that you take care of your child. That culturally was a super important thing. So promoting independence kind of went against this kind of model of the way I show my love is by doing all of this care. So I think we need to really attend to that. And when we think about what it means to provide family-centered care, what it means to promote self-efficacy and self-determination, and then therefore the owner taking from the CEO, from the parent over to the child, and knowing what we have to offer and what people come to the table with. So I have painted a picture that's not necessarily so bright, and I haven't offered you anything. So what I'm going to offer you is on the margins, stronger communication, better respect for people's differences and where they're coming from, engaging the rest of your team, kind of the best mechanisms that you have in our armamentariums, because we all have them in our doctor's kits to do this. And take opportunities where they might be. So for example, in our setting, we're doing parent-based problem-solving skills training. Our team got so excited about this, and they started talking about all the things that parents needed to do to learn how to take care of their kids. Well, this is actually not meant to be directed by what the healthcare team wants. It's meant to be directed by what the family, the parent wants. And wow, that's so empowering. The parent gets to decide. They get to address the issues that they want to address. And this model is very successful. It takes 8 sessions. A trained professional that does not have to be PhD level can do it with them and give patients and families tools. So when you think about the difficult parent who is stomping around and that's the only tool that they have in their toolbox to have their voice be heard, yeah, we shouldn't call them difficult parents. Thank you, Dennis, for pointing that out. But that's how they're experienced by the team. And we need to meet families where they are, help them develop tools that they might not have, access resources that extend well beyond the healthcare setting, and develop and promote autonomy and self-efficacy. Thank you.
Amy, thank you so much for that really stimulating talk. And now Susan Edgman-Levitan is going to talk to us. And what I understand is that she's really an expert at harnessing the energy of patients and families.
Oh, wow, thank you. I do not have slides. I don't typically spend a lot of time in the pediatric world, so I'm bringing you greetings from the adult world, particularly primary care. And I'm also sort of reeling from PTSD right now because the thought of getting my daughter as a 3-year-old dressed still causes such anxiety. Getting those seams straight in the tights resulted, which I was rarely successful, and sometimes got 3 a.m. phone calls from my husband who was trying to do it. So she went to school a lot in her pajamas, but she's survived and is a nice grown-up. So anyway, what I'm going to be sharing with you today is some of what we've learned about self-management from the adult world of care, and also given the conversation in the first panel, I can't help myself, I can't refrain from sharing some very practical tips and some of the challenges that I face, that I think we all face, with getting patients much more involved in the design of care. So very quickly, I think you've heard 2 absolutely stellar presentations about self-management programs in the pediatric world. I think in the adult world, the one thing I would say, and I suspect it's true for all of us, is that we are still very much in an aspirational stage. We have a lot of theories. We know that certain models work, but we still are very challenged about how to actually integrate models of self-management, self-care into our workflow. Time is an enormous challenge that we face in this area that I think we really have to focus some serious design attention on in terms of how we design our visits, how we design the process of care. I think the teamwork models you heard heard earlier today are also critical because it helps with some of the time pressures on physicians. I also think it helps with decreasing the power hierarchy so that patients and families feel much more comfortable talking about things that they don't necessarily feel comfortable talking about with physicians. I was at a meeting yesterday that was focusing on failure to diagnose, and one of the big challenges that we know we have there is actually getting patients to give an accurate history, which is often limited by the physician not letting them talk and not letting them actually talk about what they've experienced and what concerns them. And so I think that, we have to think a lot about these issues. But from the perspective of self-management in the adult world, some of the people that are my heroes in this area are people like David Sobel from Kaiser, Kate Lorig at Stanford, Ed Wagner at Group Health with the chronic disease model, who've all created very effective strategies that help educate people primarily with chronic conditions, sometimes lifelong, sometimes they're self-management programs for insomnia or menopause that aren't necessarily going to affect you the rest of your life. I think that these are often led by a combination of patients and an RN, patients and a health educator, physician, psychologist. It sometimes depends on the organization that's sponsoring them or the nature of the condition. But I think that one of the things that has always been very interesting to me, because I've also had, I was diagnosed with rheumatoid arthritis when I was 20, and that was quite a wake-up call about many things in life, including some of the best lessons I think I've ever gotten about how to live a good life. But I think that one of the things that many of the people that have been most successful in self-management programs have learned pretty quickly is that we worry a lot about what kind of knowledge we have to pack into the heads of people when they come to these courses, and it's much more than knowledge. It's confidence, it's all the things that you heard about earlier, and other patients with those conditions are often the best teachers. And sometimes when the people leading these programs have gotten the confidence to let go of the control and let the patients determine what they want to talk about, in what order are they going to talk about the various things you need to learn, what they find very quickly is that people actually address all the same issues that they were worried about covering, but they do it in their own way, and they do it in a much more effective way. So these are often available for people with diabetes, arthritis, cancer, stroke, many chronic conditions, and I think we have a lot of evidence about the power that they give people, but they're still not built into the mainstream of care, at least not in my world. And a lot of that is actually related to reimbursement. How do we pay for the staff to run these? How do we find the time? And frankly, it's often affected by the physical environments that we work in. Most of our primary care practices, the only room that's big enough to bring a group of people together is the waiting room. So we haven't thought about the structures and the reimbursement that we really need to think about to make these happen. And I suspect it's very similar in pediatrics. So I also think that one of the things I've learned that's been extremely gratifying in the face of a lot of resistance is, as we in our healthcare system, and you're going to hear more about this from Tim Ferriss in the panel after lunch, as we've focused on population health management, and we focused on how we take care of the people that are the most high risk in our system, which is Partners in Boston, we decided that we were going to take our primary care practices, and we have about 233, through NCQA PCMH recognition. There was a lot of concern about just checking the boxes. There was a lot of concern about, will this really make a difference? But we had to have a framework that we could hold people accountable for if we were going to invest the resources necessary to do this. We combined the recognition program and everything you need to do with that with an internal program that created incentives for doing things that we think are very foundational. So those included things like doing huddles in the practice, having an MA one-to-one ratio with the physician, getting people enrolled in the portal, all the things that we knew that would be very supportive of the model. And it also included our high-risk care management program and making sure we had care plans. So one of the things that I've learned in this work is that one of the requirements is that you have care plans in the chart for people. It was originally people with 3 chronic conditions. So we selected, in the pediatric world, we selected well child care, asthma, and ADHD. And in the adult world, we chose depression, diabetes, and hypertension. The program has now moved on that it can just be anyone that's considered high risk. So you have to do a chart review that shows that you have a care plan, and the care plan has to include the patient's goals. To me, this is a linchpin about educating our clinicians about what real patient engagement means and how we can avoid what I have come to think of as almost pathological, magical thinking, that we tell people to do something and therefore they're healed. We're all done. We don't have any more responsibility. And at first, our physicians, and we still have many that are very resistant to this, why do I need to do this? I know what their goals are. You know, it's completely unnecessary. And all of a sudden, lo and behold, as they started doing it, they were stunned. They had no idea what their patient goals were. And the way that their patients framed their goals was entirely different from the way that the physicians were thinking about it. So one example was one of our physicians in our geriatric practice had a patient, an elderly patient, that really needed to lose weight. So every time this person would come in, the doctor would say, okay, you've really got to lose 10 pounds. So then he decided to ask the person, okay, what do you care about? And the patient's response was, well, I think my goal should be I will have, instead of having 5 meals at McDonald's every week, I'm going to have 4. Let's start there. And that was a real eye-opener for the physician. It never occurred to the doctor that this is how this person was even eating. And now they had a place to start. There are many, many examples of this. The other thing that I find really wonderful is that now when our doctors are taking care of each other's patients, they actually see these goals and they can speak to them. Because before it just said what the physician or the nurse practitioner or PA's goals were. And again, that was a little bit of imaginary thinking. So I think that we've learned a lot from that, and I would recommend that if you're in the same world trying to do this, it's really worth fighting through the resistance. Because some of our physicians that are now doing this on a regular basis are our biggest champions. So I wanted to share that. And the other thing that we learned in the course of doing this, and again, I suspect this is pretty common in pediatrics, is that we could barely find anyone that had ever actually had really comprehensive, effective training in motivational interviewing. And I thought, gosh, we just haven't really called this out as something that we need to do. And my center runs a lot of educational programs that help support this work. So we started looking around who can teach motivational interviewing. We have thousands of doctors. We have thousands of nurses. We identified 5 people that really had gone through effective training, that felt very competent in doing this. And you can imagine they were completely overwhelmed with the demands for their time. So again, I think this is a competency that we really need to develop. I'm also involved in an organization called Primary Care Progress, that is an organization that really is trying to create interest in primary care in medical schools, other health professional schools, and residency programs. They have a big leadership conference every fall, and I often get asked to come to talk to the students and it's not a lecture at all, it's just to talk with them about various things that around patient and family-centered care, shared decision-making, and PCMH activities. So I always ask them, what kind of training are you getting in motivational interviewing? What kind of training are you getting in real communication and engaging patients in their care? And I hear crickets. And this is all of the top medical schools are there. And they don't even know what I'm talking about. So we have to start way upstream, I think, with a lot of these strategies. Some of the other things that I think we found that are very important, and again, I know that Tim is going to be talking about these, but, you know, in looking at the slides in the first session, there are care coordinators all over the place and care managers, which is incredibly confusing. You know, years ago at the Picker Institute, we did focus groups all over the country to try to get a sense of how patients felt about their care, and we would ask them questions about the healthcare system, and almost to a person, no matter where we were, they would start laughing, and they would say, well, that's an oxymoron. We have no healthcare system. So I think what we have learned is that, and I think many places have learned this, is that embedding care managers in the practice where the physician can transfer trust from him or herself to the care manager, the person that's coming in for care sees that person, knows them, and knows that they are accessing all the same clinical information is profoundly important. And I also realized this when I had my own experience with care management. A few years ago, I had a parasite infection that was quite complicated, actually, in some respects, to diagnose. And I was in the hospital. I had to get all these tests and whatever done. And all of a sudden, I found myself in the care management program at Blue Cross. And I started getting all these phone calls. And I'm like, I do not want to talk to these people. But I finally did, because they were really persistent, and they started leaving me fairly menacing voicemails. So I got on the phone with them, and they said, now, Susan, we need to talk to you about your rheumatoid arthritis. I'm like, why? And they said, well, that's your problem. And I'm like, no, it's not. I said, I could teach your RA program. That has nothing to do with what's wrong with me. Fortunately, I have friends at Blue Cross, and I actually ended up getting my name on the no-call list because it was horrible. And I was sitting there and I was thinking, I knew the evidence showed that these external programs aren't very effective, but experiencing it personally was very eye-opening. And all I could think about was what a tremendous waste of money that we could be using in much more practical and effective ways. So I just want to share that with you. One other thing that I think that we really need to think about when we're thinking about, we've heard a lot about how we can enhance resilience and efficacy, but we also need to think about how we provide people with information. For years, it's been so frustrating to me when we hear physicians and others talking about all the dumb questions that patients ask, when we purposefully prevent them from getting access to any clinical information, certainly not their own medical record. I can't tell you how many times I answer questions from staff about, well, we can't give this person their own information because of HIPAA. So really, so I think that the more that we can do to make everything in the record transparent, and this came up again yesterday. I actually get my care in a system in Boston where they founded open notes, so you can actually see your clinical notes. It's like reading a fairy tale on certain occasions about, I know I never said that, but it's there. So I think, and you can get it corrected actually, which is quite helpful. But I think the more that we can make the information transparent in plain language to the people that we're taking care of, the more that we give them at least a fighting chance to understand what's going on with their care, what's going on with the care coordination, and what they can do to make a difference. So I know my time is limited, so I want to just shift gears for a second and talk about, actually I don't want to shift gears yet. One of the things I also want to say is that we've thought a lot about how we transition children with complex health needs from the pediatric world to the adult primary care world, and we have huge issues there. We have not educated our clinicians about the clinical aspects of taking care of these children. It's a huge undertaking that I think we need to pay serious attention to, given the number of children that are coming through the healthcare system now. We also have not, I think, I'm not sure what the right word is, possibly prepared our adult PCPs and everyone on the care team for dealing with a group of extremely empowered and engaged families. That's a whole new thing. They're used to taking care of elderly patients who often have families that live afar, or it's a spouse who may be equally challenged. This is going to be a whole new universe, and we've got to think about that. And I think we have to think about that very carefully, but also quickly. So the other thing I'd like to just spend a couple of minutes on is, it was a little bit depressing to me this morning to hear about family-centered care still being somewhat theoretical, and not necessarily as applied as I have presumed it is in the world of pediatrics. And so a few things I'd want to share. We've actually engaged patients in many different ways to give us advice about all sorts of redesign issues, patient education materials, whatever. But a couple of just practical points, I think, and there's a tremendous amount of information and wonderful guidance about this through the Institute for Patient and Family-Centered Care. So I don't want to take up time with things that you can easily access, but choosing the right people is critical. I think Alan referred to choosing the wrong person and how that can set things back. I sometimes laugh when I think about the criteria, because it's the criteria that I use for anyone I want to work with. They're a good communicator. They can pay attention to other points of view. They know how to deliver criticism constructively. They have the right experience of illness for the task that you're asking them to focus on. And hopefully they have a really good sense of humor. And they're not incredibly angry, which is always a challenge. The other thing we've learned is that if you really create a full-blown council, give everybody a one-year term. That gives you the opportunity to gracefully say goodbye to people that may not be the right fit. I also think that we have to be very careful when we're thinking about partnering with patients to think about what is the best method of engagement to fit the problem we're trying to solve. If you're trying to completely redo your workflow in your practice, you need a group of people that can stick around for a while. If you're thinking about, if you've got a patient education brochure or some sort of educational material that you want to share with your patients, you may only need a few people to review that once and you're done. And I would also say, at this point in time, given our work on that front, I would never think about giving out any information to patients that they haven't reviewed. Because one of the things that we often find that's scary is that we share educational materials with them. They don't understand it. It doesn't address their biggest questions, so they don't use it. We find it in the parking lot garbage cans. We find it laying around in the waiting room. And what it does when we don't design it right is it reinforces the perspective of the clinicians that they don't care, they're not interested, they don't want to be engaged. And it's not end user failure, it's design failure on our part that we have to fix. I think I'm out of time. I think I have 40 seconds left. So I would just like to end with something that is my dream, and that is that we move the way that we're interacting with our patients from only focusing on what is the matter to what matters to you. I also think I heard a quote yesterday that's one of my new favorite quotes, that is, I don't care what you know until I know that you care. So with that, I'm going to end. Thank you.
Well, I promised you a spectacular panel, and they have not disappointed us. We do have time for a couple of questions, but I just wanted to make one or two observations while people are coming up to the whatever these things, microphones, yeah. And the two things I'm thinking about were that last week I was at a meeting which was called Building Inclusive Communities. And it was a very different meeting from this one. I was one of two physicians in the audience, and people didn't realize that, and so they told us what they thought about doctors, which was not much. And that was a little bit of an eye-opener. And the fact that we need to hear things like that over and over again, I hope that as we make meetings, we will be more inclusive of a sort of a broader group of people so that we can hear that what's happening is that we as physicians are being seen as people that don't listen, that don't look, and that are not willing to sort of step aside for some innovations. And those are hard things to hear, but I think we're getting some sense of that from some of the activities here. The second thing I just wanted to mention was another meeting, which was a Family Voices meeting, and I was very struck by the homogeneity of the population that was at the meeting. And that was great, and it was a good meeting. I was going to present some things on community health workers, and I looked at it and I said, well, maybe this isn't the group that's going to be so interested in what I might want to say. But then we broke for lunch, and there was a meeting on leadership. And the group that came into the meeting on leadership were from every community in Boston. They were now concentrated in the room, and they were ready for action, and they had lots to offer, tremendous strengths. And I hope the kind of strengths, Amy, that really would be able to help families who are in the kind of struggles you're talking about, have neighbors, have community resources, have those kind of priority setting available there. So just as we talk about this activation and coaching and so forth, I love the model that Partners in Health is now talking about, accompanying people through their journeys rather than leading them. But now we've got lots and lots of people lined up, and I'm sure tremendous questions. Yeah.
Thank you. I'm Jeff Schiff from Minnesota, and this was a really wonderful panel. And Amy, I wrote down, I didn't bring it up here, but your thing about the endowment that we bring, because I think that that's really important. My comment and question is really about sort of, I feel like we need a new PAM, which is not a patient activation, but sort of a policy activation measure. And I guess I want you guys to react to this, because I feel like, so the story is that at 11:30 yesterday morning, I found out I had a new commissioner who has no healthcare experience, but seems like a nice person. And I'm thinking about what I need to develop a trusting working relationship with her, like all of us need to work with. We want a trusting working relationship with our families and in our own integrated teams. So I'm thinking about writing to her about why I like my job, which is true. I really do like my job. But I just feel like what we do is we've learned a lot about the science of care coordination and involving families, but we need together to figure out some way of translating what we know about science to our policymakers in a way that catches them at their developmental level, wherever that is. So, and that's not disrespectful at all. It's just really about the fact that some of them have really been enmeshed in this and they get it, and others aren't, and they want to do the right thing, but they need to know. So I guess I'm curious if you guys have approached policymakers about this stuff. If you have suggestions about that, what do you think about my crazy idea?
So I have not approached policymakers about this stuff in particular. I feel like the pediatric self-management support field is behind the adult field in terms of really knowing, like, what do we tell providers? What do we tell healthcare teams? What do we tell people who are designing programs? I feel like, this literature review that we did showed lots of interesting stuff going on, but really not much in the way of take-home lessons. Like, we don't know what's effective, basically, I would say. Others in the room might disagree. But I think that I would be interested in knowing what's happened in the adult world in terms of understanding the policy implications of self-management support work, because hopefully we can learn from that.
I'm going to speak to the self-management, but also the patient engagement world, because in the patient engagement world, I've spent probably 30 years trying to get funding to support involving patients in redesign and in many aspects of helping us improve the way we deliver care, and have been, for the most part, unsuccessful with government agencies, with private foundations. The only place we've had success is with donors. And I think that it's a huge challenge because everybody says it's so important, we really need to do this. And we say, well, if we really need to do this, these people don't work for free. And we need to find funding to support this work, and that's the end of the conversation. And it's even been challenging, I think, with PCORI in terms of having them really understand what this means, what this looks like on the ground. It's not an RCT. It's not a comparative effectiveness study. It's much more complex than that. And so I think that is extremely important for us to think about so that we can make this real. We are challenged by even figuring out how to pay people when we actually have them engaged. What mechanisms do our healthcare organizations use? On a more positive note, in 2008 in Massachusetts, when we passed the health reform bill that created universal coverage, it also had a piece in it that required every hospital to create a patient-family advisory council. We still have a long way to go to make those as effective and powerful as they can be, but that certainly laid the groundwork. And every hospital has to file a report every year about what those groups are doing and what they've helped them do on the improvement front. And with self-management, I think it's really how do we reimburse people for doing this, and how do we reimburse people that actually have the right skills, like coaches and people that are exercise physiologists, or people that aren't a physician or a nurse, who may be the most able to do this well.
I'm seeing a long line, so I'm going to ask people to come on up with another question.
Hi, I'm Rylan Rogers. I'm from Indiana, and I really appreciated this conversation. I particularly appreciated the attention to consideration about kind of what's a reasonable ask for families given their cultural background and what's possible in their communities. I wanted to hear a little bit about how we can influence systems and services and providers to provide opportunities to practice self-management. I think many youth have lovely skills. I was very privileged to learn early from self-advocates about beginning with the end in mind in my own family and really developing some lovely skills from very early childhood, but they weren't always received well in an opportunity to practice. So how do we shift to pivot and allow children at all ages to appropriately engage in every medical setting that they're experiencing?
Well, I'll take a crack at that. So obviously we were thinking a lot about that in our focus groups. We ended up recruiting patients from several specialty clinics at Seattle Children's, and happened across these great little programs that were, in cardiology or in, particular specialty clinic, or targeting even a particular disease. And there's good work happening, and I would say, just like with adult self-management, really good providers were figuring out how to help families with this stuff before academicians came along and built models. I think the models were built in part by observing really good practices, right? Mm-hmm. So I think that we need to make this part of the conversation. We need to make it part of our assessment to say, where are you? Who does what in your family? How does your family system deal with the tasks of self-management? And what do you think is going to happen tomorrow? And what do you think is going to happen in a year? And I think and the answer to your question is a little different in the primary care setting versus specialty setting. But I think the answer is I could give you my opinions and my thoughts about it, but the research is not there. So I think that this is ripe for understanding. Let's try something and evaluate it.
I think that's really rings true. Is there's many places and many systems that are doing great things in this arena, and we often then just go and try to recreate a wheel in our own setting, and not taking from, let's say, the wraparound services that are available for psych services and learning from that. And I think that there's a tremendous opportunity. We're working on, for example, transition from inpatient to outpatient. So we don't let you take your home medicine when you're in the hospital. So we're just going to give you a bunch of prescriptions, and now everything's all different, and we're going to have you fill them on your way out the door. Well, that's completely unreasonable. That's not a good way for us to teach you and engage in a process of feeling capable of doing a task once you get home. So we have to change things at very fundamental levels of how we do business. We have a process, and we're lucky to have it, where we have families on inpatient rehab for weeks, and we have training goals that are shared that exist for the child, for their development of functional skills, and for the families. We have programs where we bring families in to take over at higher degrees of managing the care over the course of days. We expect for the last 2 days that we will have their medicines in hand from the pharmacy, and that they will be administered by the patients and the families themselves with oversight, and then eventually a launching system. So instead of drop kicking a patient and a family into the abyss of the outpatient world, we are doing things to try to mitigate that experience, the negative aspects of that transition experience. But we have a lot of work to do. And as we're turning over beds in inpatient settings, and we're worried about our 15-minute appointments, and we're trying to figure out how to pay for our case manager, all of these things interact. But I think you speak to something that's really important. We have programs that work. We need to replicate them. We need to plan and do them and study them, and then continue that process.
Love to continue, but let's go for another.
So this is guest directed most at Susan, but everybody else can comment too. The whole issue around transforming culture, and Susan spoke to this. There were only 5 people in the system who could teach motivational interviewing at Harvard. There were a lot of different issues. Is the whole question about joy in practice. So, if you look at primary care across the country right now, essentially what we have is a battlefield triage system that doesn't work for anybody. That doesn't work for the patients with any kind of complexity. It certainly doesn't work for the providers either. And they're struggling to make it. And so I think. Chris in the previous session put up a slide that was sort of a mission statement, and it had the language of meeting the needs of patients and families and having the capability in the care team, but it left out meeting the needs of the care team. So I get to, in the thing I get to do with medical students, I get to say, relax, you're less important than you think, to them. What we found is just tremendous joy in the new model, where it's a collaborative model, where you're not the expert all the time, and working in teams. And so to Susan, how are you measuring that? How do we start making that story more prominent? Because I think it's not like people are holding on to something they like. They're stuck in a horror. Well, and all you have to do is look at the low numbers of people going into the field to know that.
I think people are holding on to something they know. They don't necessarily like it, but the new is often scary. But one of the other things that we're doing, when I mentioned that we had these foundational programs to support patient-centered medical home transformation, one of the other ones is that we have administered the medical office survey of patient safety culture in all of our practices. And we've done it. We are just finishing the second round, but after the first round, as part of their incentives, all of our practices had to come up with what we called a culture transformation improvement activity. And this has been really eye-opening for me because we had about 22 practices that were at the top on that survey in almost all the domains. They were above the 75th percentile. They were also our top performers in terms of patient experience data, health outcomes, safety issues, and they also provide care at a lower cost. So, you know, it's the triple aim. But I think culture is actually the real foundation for this. And one of the things that we're learning that all those practices do, that a lot of our other practices are adopting, is they have all staff meetings. They actually come together and talk in person. No email, no texting. They actually are getting to know each other as people. And we're also finding when we're trying to build stronger cultures with our physicians and our specialists, they are all so hungry for personal interaction. I think the quickest way to describe it is our physicians miss the doctor dining room, where they could go in and see their colleagues. We brought together specialists and primary care doctors, and I was stunned. They had been sharing patients for years. They couldn't pick each other out of a lineup. They knew each other by email, and that was it, or the telephone, their pager. And so I think bringing back community and really paying attention to the culture and measuring it and then focusing on where you need to improve, I think we're finding is incredibly effective, although challenging.
Great. Nora?
Well, thank you so much. I'm Nora Wells from Family Voices. I'm the executive director. I just wanted to bring up an aspect that I haven't heard pulled out in quite this way, and that's the aspect of what a diverse culture we live in now, with families from Somali backgrounds and migrant people coming in and Native Americans who've been here for a long time, American Indians. We are a culture that is completely diverse, and many of these strategies that have been developed, especially I would say to you, Susan, I think in the adult world, are really the assumption that you've got the average white middle-aged person who's going to be sitting there and listening. So within Family Voices, because it was founded by families who have fundamental experience that's absolutely an equalizer. There's nothing that qualifies you to have a child with special needs. Everybody gets one. And it's, you know, there are some groups that have a little more higher prevalence, but it's pretty divided across the whole community. So we've worked on this for a long time. And what we find, and this is the question I want to ask you, is it takes more time and more money to help the family leadership develop from the more diverse communities, because their expectations are not at the same, and the amount of time it needs for people to come to understand the systems takes longer. So I would call out the Maternal and Child Health Bureau. That is an agency in our government that has recognized the importance of all the constituents who receive their services being part of the solution to what should the services be, how would we design them, etc. When the Ryan White Act came along, we worked with the Bureau to bring in the families with HIV and AIDS. They were not the usual families that the Bureau worked with. Absolutely, they designed a fantastic program. So we know these families, every family can do it. But we have to put the resources in the area that's going to help some of the more diverse families take a role. And we actually have a leader here who's working with, I think, the Somali families, Carolyn, right, in Minnesota, and helping them become leaders, not just become partners, because partners in care is very important, and then we need leaders who are on teams and committees and things. So I don't know, Susan, whether you have any comments or anybody else. I haven't heard the culture piece.
I totally agree with you. I can share a very quick anecdote. Several years ago, we were trying to improve the completion of healthcare proxies in our primary care practices. And we took an approach, instead of letting it fall on the shoulders of the doctor, to run group sessions where people could come and hear about what that means. How do you think about who you choose? What's the role, et cetera? We had a health center that is actually in the area of Massachusetts that has the worst health outcomes, Chelsea. And they have a Cambodian population. They have an incredibly diverse population. Their clinician said, this is never going to work here. So we said, okay, let's try. So we did focus groups in Cambodian and in Spanish with the Latino population to talk to them about, okay, here's what we're trying to work on. Is this something you're interested in? Is this something you would do? And they were all incredibly interested in it. But the way that they approached it was entirely different. And when we paid attention to that, where it's not just me deciding who's going to be my healthcare proxy, it's probably my grandmother deciding who's going to be my healthcare proxy, and we brought all those people in, then it worked. So I think the point is we have to apply the same patient involvement in how we design what we're doing, no matter what population we're talking about.
And I would just mention that the peer support
Yes.
for the family coming from the Cambodian to be part of that design is really important.
Yeah.
Thank you so much. That would love to continue this particular conversation for a long, long time. But we have 10 more minutes for questions, so I'm going to ask each person to be kind of shorten your question, and unfortunately, I'm going to ask my panelists to be short in your answer.
I'll be very brief.
High priority.
My name is Judith Schaefer. I work at McCall Center at Group Health Research Institute and have been involved in self-management support, training of clinicians, and development of materials to help support self-management in primary care, adult primary care, for 20 years now. There's a very particular aspect of this, and perhaps it's implicit in the idea of goal setting, which seems to be central to what people operationally think about self-management support. But I fear that when we talk about goal setting, we can really blithely think about setting goals. Even if we think about setting patient-centered goals or setting them collaboratively, we still aren't remembering that really important translational piece that Kate Lorig and others, I'm also a T trainer for Kate Lorig's chronic disease self-management program, but we forget about the action planning part. We forget about the bridge that takes self-management out of the clinical setting and brings it squarely into the lives of the people who are going to do the activities that make the difference. So I would encourage us all to think really carefully about who in our team, on our practice team, is going to do that work, how we set aside the time, and really more important, equally importantly, how we follow up with that person. None of us is successful instantaneously in doing any of these activities. And with complex patients, children particularly, there's a lot to learn and a lot of trial and error that goes on. They need a really personal coaching relationship with somebody who can help them begin to learn and gradually build the successes that makes for confidence.
Maybe Susan, you could.
And I'd like to say one more thing, and then I'll just stop. I'm sorry. I think that we do a great disservice to patients but to all of us, by engendering hope that we can do something more, that by encouraging them to take on their self-management roles, and then not supporting them in gaining the expertise they need to succeed, and they become dispirited. So I would just encourage us to be more pragmatic about them.
I'll just say, I think what you're talking about is absolutely right. And action planning takes time. For those of you who've done it, you know what I'm talking about. I mean, and I think that's getting back to Alan's earlier conversation about medical assistance. I think we do need to be thinking about this self-management support work as a team function, and it's not a single provider who is supporting families in this way.
Can I make,
Hi, Rita
I'm afraid
Mangione Smith from
we really have a number, and
from Seattle. Totally different direction, but boy, it's a theme through so much of what I've heard from this awesome panel. Thank you so much for the presentations. Is there anybody in this room who is focused primarily in their professional work on graduate medical education? That is a missing stakeholder group here. It really, really bothers me because I think what we're hearing over and over again is something I've struggled with all my professional life because I was dumb enough to think I could change doctor-parent communication early on in my career. Really frustrating to change provider behavior once we're already trained and out on the front lines. We need to really, like somebody said earlier, get further back in the training process. Why isn't motivational interviewing part of what we're training medical students and residents to do? It should be a required part of their curriculum. It should be part of their board certification. I mean, it's just, why don't we treat them, Amy, to like meet a patient where they are and ask the right questions and really listen so that they understand what that family's capable of? You know, I feel like until we back that up and we start training physicians and physicians and everybody in healthcare system in a fundamentally different way, we're going to have the same conversation 10 years from now.
I'm going to take the prerogative to answer that question with Jeff Goldhagen and Richard Pan sitting in the room. Some of us have been working very hard on that question for a number of years to have much of our community training for our residents, and this just changes the way that they look, the way that they ask, the way that they behave. And I want to tell you that there is hope because we've got a diverse and an exciting and a joyous group of residents coming through. They're ready. What's not ready, is the payment systems that are needed to support them. But the training's going on, and they're going to innovate and do some exciting things. Jeff?
Yeah, I'll be really quick. Actually, as we speak, December 16th is the due date for a new primary care training grant, which I have right here, which is all about integrating all of this work. So I'll be uncharacteristically quick. I'm going to change my name to Sven because this is another Venn diagram. And that is in particular the intersection between what you're talking about, children's rights. Nobody around the world would be talking about self-management the way we talk about self-management for children. They'd be talking about fulfilling the rights of children. So if you go back to the Convention on the Rights of the Child, it's Articles 2, 3, 5, 6, 12, 17, 31, 24, to name a few of the articles of the Convention on the Rights of the Child that speak to not the generosity of what we're doing, but that, in fact, the issues we're talking about are related to children's rights. Jerison Lansdowne, who's a close friend and colleague, has done a huge amount of work in this area. There's a huge amount of research. There's a huge amount of data. Unless we move to the child rights perspective and explore that data and explore that environment, then we'll be missing actually what's happening in the entire world, certainly high-income countries and middle-income countries as well. That data is really, really important to our work.
That's such an interesting perspective. I had not thought of that
in
this work.
And the UN Convention on the Rights of People with Disabilities, right? Which is the latest convention, newest convention. Jerison wrote that. What did she do? She brought in about 50 disabled children from around the world. They wrote it. They presented it to the General Assembly. So that work's already being done. And one last comment, the whole area of narrative medicine that comes out, and particularly out of Columbia in their work in Columbia, is a huge resource for us because that, in fact, is what we're talking about, and that's the movement. So I'd encourage you to reframe what we're talking about in the context of a child rights-based approach. There's there's rights-respecting hospital movement, there's rights-respecting child care movements. Huge amount of work that's out there for us to be able to use and apply to our work.
I guess you just didn't read my dissertation.
Well, you know what? You never sent it to me.
So actually, that was a big piece of looking at it from the lens of child rights or human rights, because certainly in the disability literature, that's extensive in how we think about what it means to be a person with disabilities.
Okay, we've got one more question and then lunch.
So I just want to give a plug to where there's two pediatric psychologists here that I know of, myself and Danny Armstrong. And there's actually a very rich literature on self-management and adherence. He's a past president of the Society of Pediatric Psychology. We have a Journal of Pediatric Psychology. And I would say 70% of the data that's presented in there are around adherence and self-management in medical complexity and chronic illness. My CV is unfortunately littered with those studies and outcome studies demonstrating effective strategies for improving self-management and adherence in youth with medical complexity. So we need to get out of our silos and know that I love the comment before about the mental health side and the medical side not interacting. This is just another example of our siloed thinking, even in what I would consider a pretty enlightened group, because
I'll say that
there is a lot of information and literature and outcomes on strategies for self-management.
Yeah, and about a third of the literature that we looked at was from the psychology literature, that journal and others. And in fact, the psychology literature tends toward the family theory models and complex theories, complex system theories, and the biomedical literature tended more toward the self-determination work, but there was a fair amount of crossover. I will say that adherence per se is a narrower construct, and I would say perhaps more of a provider-centered construct than self-management, which really talks about owning it and living a life.
Just quickly, all of our MI experts were psychiatrists that we identified when I mentioned before when we were looking for people to help with training. Yeah.
They were.
Well, I want to thank this excellent panel and have you